Good afternoon and welcome to all, including colleagues from the Department of Health and our community members. I'm Savita Pahwa, Director of the Miami Center for AIDS Research, and my co-host is Dr. Stephen Safren, Director of the Miami AIDS Research Center, known as CHARM. Today, December 1, is World AIDS Day, and we are proud to commemorate it by showcasing the work of our investigators on ending the HIV epidemic, dubbed EHE. I want to thank all the people who have worked hard in this effort and to acknowledge Drs. Stevenson and Colbert. Although overshadowed by COVID-19 this year, HIV/AIDS remains a formidable challenge that surfaced 40 years ago. The EHE mission started with the 1990 UN AIDS initiative and was geared towards treatment to get art to all HIV-infected persons globally and end the epidemic by 2030. Although still short, enormous strides have been made with art. Today, 38 million people are alive and living with HIV worldwide, 1.1 million in the US. But there is still no cure or vaccine, and new infections continue to occur. These are especially high in our area and are increasing in Latinx MSM. The new EHE initiative is geared towards prevention. It was born in February 2019 with President Trump's announcement at a State of Union address of a plan to end the US epidemic by 2030. HHS operationalized the plan and allocated resources to implement it. Next slide, please. Now, how do we come into the picture? In this EHE plan, a national survey for HIV/AIDS hotspots identified 48 counties that account for more than half of new HIV diagnoses. By the way, Florida has 7 of them. Look at where the CFAR's red ribbons and ARC's blue ribbons are situated. They are in close proximity to HIV hotspots. Next slide. With new additional funding, NIAID and NIMH issued calls for EHE administrative supplements and grants to CFARs and ARCs to develop novel strategies to diagnose, treat, prevent, and respond to HIV. And our investigators were quick to take the challenge. Steve, will you please introduce them? Thank you.
Hi, everyone. Thank you for coming. And so we were able to get a good handful of supplements through the CFAR and the ARC. And the amazing thing about them is that they really are addressing populations that are so important to be working with in the Miami area, where, as people know, Miami is just such an incredible HIV hotspot, with leading the number of new infections around the entire country. So the first 3 that are listed here are the CFAR and the Epidemic supplements for the fiscal year 19 and 20. And the first one is with Hansel Tukes and Susanne Doblecki-Lewis, looking at mobile delivery of PrEP and medication-assisted treatment at the Syringe Services Program pilot. And this one is a pilot implementation science project using the treat and protect pillars, focusing on the acceptability, feasibility, and disseminability of PrEP and medication-assisted treatment delivery at Miami Syringe Services Program mobile unit. And it has the goal of enhancing availability and uptake of these services to the Black community of people who inject drugs. And then the fabulous Susanne Doblecki-Lewis has another one that is looking at mobile prevention services to respond to expanding HIV clusters in South Florida. So utilizing the mobile PrEP clinic that she runs, that's allowing for targeted delivery of biomedical prevention services to priority locations and populations. And that can be determined by near real-time genetic distance network transmission data obtained by the Florida Department of Health. And I believe she'll be talking more about that today. And then we have Allan Rodriguez, looking at an evaluation of the rapid linkage to care and antiretroviral initiation program that he runs. And that's addressing the treat pillar of the epidemic initiative. And it will identify barriers and build strategies to expand the implementation of rapid antiretroviral therapy throughout Miami-Dade County, rapid initiation that is. And it will systematically identify multi-level barriers to TRRT implementation and novel implementation strategies that can overcome these barriers. Next slide, please. Then our second table here are the same fiscal year of supplements that were awarded to CHARM. Hansel Tukes is looking at telemedicine, test and treat for on-site initiation of antiretroviral therapy at the Miami Idea Exchange syringe services program. And then we have Mariano Kanamori, who's speaking today about the Finishing HIV project, which is HIV protection, diagnosis, and treatment network for Latinos. And it's looking at pharmacy network and PART networks to increase awareness and utilization of HIV protection, diagnosis, and treatment services by Latino men who have sex with men in Miami-Dade County. And then we have Sannisha Dale, who's also speaking today, who's I can't really quickly explain this project because it's so innovative and cool. Not that the other projects aren't, because they are as well, but focusing on Black communities in collaboration with community consultants and community organizations, looking at ways to basically meet people where they're at for HIV prevention and treatment services. Next table, please. Then we got another set of awards for this fiscal year. And the first one, Dr. Rosina Cianelli. Did I say that right? Yes, maybe, close. Okay, close. She'll help me with that. And that is a project on reaching cisgender heterosexual women with PrEP. And it will target rural cisgender heterosexual women between 18 and 49 living in Homestead, Florida, who are at risk for HIV, doing lots of amazing community engagement work to do that. Susanne Doblecki-Lewis, adaptation of the mobile PrEP implementation strategy for equitable scale out, and called AMP Out, which is testing and implementation strategy, the mobile PrEP that was developed, which involved a delivery of care through the mobile clinic, bundling services again, and looking at two different implementation strategy elements, navigation from community testing and social engagement. And unfortunately, this one we will not be hearing about today. And Audrey Harkness is presenting her Career Development Award, which is focused on developing and pilot testing a culturally grounded multi-level implementation strategy to scale up and disseminate PrEP, HIV testing, and behavioral services to Latino men who have sex with men. And then final slide, please. Some more awards funded for fiscal year 20, Mariano Kanamori, basically year 2 of the project that I mentioned before, and Sannisha Dale, years 2 and 3 of the project that I mentioned before, continuing those along. So without further ado, we will begin with our first speaker.
Should we tell people about the question and answers?
Oh, yes. Thank you so much. I was supposed to do that. I failed miserably, but please ask questions using the chat or using the chat box. You can do that. Please identify the speaker that you'd like to ask the questions to. And Dr. Savita Pahwa and I will moderate asking the questions back and forth as we go along at the end of the talks.
At the end of all the talks.
At the end of all the talks, yes.
So you all have to stay for the entire presentation.
No one may leave.
Susanne.
Hi, Thanks to Savita and to Steve for the invitation to speak on World AIDS Day. I'm going to pull up my slides. And so I am going to talk about my EHE supplement from 2019. I have 7 minutes, and I am going to split my 7 minutes into just a couple of minutes of discussing the mobile clinic in general, because typically a little background is needed on that. And then I'll talk about the activities we did complete for the 2019-2020 supplement. And I will briefly touch on our 2020 to 2022 supplement, which is really a continuation and scale out of the mobile PrEP program. So background on PrEP in Miami. I think you know that we're the metropolitan area with the highest rate of new HIV infections, and that's why World AIDS Day is particularly poignant here and important. PrEP uptake relative to need remains very low, and we have documented lots of structural, social, and provider barriers to PrEP, and especially some of the things that we've noticed and have tried to act on are cost, hours, transportation, stigma, immigration concerns, difficulty finding supportive providers. The mobile clinic concept began as a collaboration with a Sylvester Game Changer. We now, I am pleased to say, have a dedicated vehicle, which you can see on the bottom right, which came to us at the beginning or the end of September. The mobile clinic provides services at zero cost to patients, and that includes PrEP labs, a PrEP visit, and prescription. Also STI testing and treatment, HIV rapid entry to care through Dr. Rodriguez's test and treat program. We hope that it is a low stigma environment that's visible in the community. We know that we have multilingual and welcoming staff. Our flagship site was the Hotel Gathering on South Beach, and we expanded to 5 sites throughout the county. As of March, when we did stop services for a while because of COVID, we resumed on October 1st. And our sites have shifted a bit in the in-between. I had to show this slide to show a picture of some of our fantastic navigators who are the heart of the program. We also have medical providers, a pharmacist, logistics manager, and you can see on the right all of the services that we provide. And just as a quick summary, overall in our first, actually this is more than a year now, I've updated this table, we had almost 500 clients. And the majority of our clients, especially in our initial operations, were Hispanic or Latino MSM, predominantly recent immigrants, mostly not insured, with a pretty high rate of STIs at baseline. So our EHE supplement from 2019 was a cluster analysis to position mobile services. So this was really a project that was to provide the support to establish this workflow with our community partners and the Florida Department of Health in order to, the goal was to go from top to bottom, from epidemiologic and molecular HIV cluster data that is held by the Florida Department of Health, to outreach and mobilization, deployment of accessible mobile prevention services, and provision of services to priority risk networks in order to ultimately interrupt transmissions and decrease the growth of those transmission networks. So all of the arrows in between are really the project. So developing the collaboration, setting up the workflows in terms of data sharing, back and forth, bidirectional, making sure that everyone was comfortable with the level of data being shared. When it comes to phylogenetic data, there's a lot of sensitivity. Developing the output and how we would prioritize those clusters, and then going through to the establishment of a new site, including community outreach and preparation of that site. So just as a summary, we did develop a method for prioritizing the geographic areas. We established data sharing. We established criteria for how to use the EHARs and secure HIV trace systems at the health department and a 1.5% genetic distance in order to look at clustering. And the sequences are reported to FDOH through December 2019. You can see from the Christmas tree, were analyzed for population level trends and resistance as well as resistance. And we looked at all molecular cluster members and individuals in risk networks currently living in Miami-Dade County. And then more recently, we've started to refine that a little bit by looking at more recent data rather than ever in clusters. So you can see the folks who were there in the room where it happened back last December. So we were able to establish a really good workflow and a good collaboration with the Florida Department of Health. That's also Marco Salemi on the top left from the University of Florida, who does molecular phylogenetics. And then we sort of had these very simple outputs, which were looking at zip codes. We also tried doing this by census tract, but that actually had a little bit more complexity and difficulty with interpretation. But you can see just in the map, the choropleth map, the different degrees of hotness in terms of numbers of cluster members. You can also see that with the blue stars, where our current, at that time, PrEP mobile sites were in the green star, which is where we decided we would go next, which is in the Liberty City neighborhood in Miami. So at that point, we worked on community assessment and preparation, particularly for that neighborhood. We worked very closely with the CHAMP program run by Dr. Sanjaya Kenya and neighborhood advocates, and did stakeholder in-depth interviews, including some priorities. HIV prevention was recognized as a priority. In-person outreach was preferred for our initial implementation of mobile PrEP. We were mostly working with electronic outreach. There was a lot of discussion of difficulties accessing services, many stories about failed attempts and a feeling of futility, and the need to establish trust through partnerships and follow through, as well as focusing maybe on STI testing and treatment in order to enable PrEP education and eventual engagement. And after all of these steps, we did have our first mobile clinic in Liberty City on October 1st, and we've returned there each Thursday afternoon since, and we'll continue to do that. So in conclusion, the implementation of our mobile prevention services is feasible and effective in engaging Hispanic and Latino immigrant MSM, and cluster analysis and feedback may be used to focus the resources for highest impact. That continues to be our goal. And we're have ongoing adaptation and enhancement of our engagement methods, which is really the heart of our EHE2 supplement, which is started in September. So I have a lot of people to thank. Many of them are on the call, and several are not. Thank you very much for the time to present here. I guess I will take questions at the end. Back to you.
Okay, thank you, Susan. I'll take over and take it from here. Okay, so this is the 5-point initiative, acronym FPI, and it's about really reaching Miami's Black communities to end the epidemic and doing it in a way where it's really going where people are. So similar to Dr. Doblecki speaking about their mobile PrEP unit, it's a lot of community focused kind of energy and input that goes into it. It's myself, but also community consultants. So the first year we had 2 to 3 community consultants, and for the second round, we actually have 5. And cumulatively, their level of expertise is extremely high. Each of them has had over 30 years of community engagement and advocacy within Miami and across the continuum of care in terms of prevention, intervention, substance use, et cetera. And so it's really a privilege to work with them. The implementation partners in terms of organizations include a range of community-based organizations providing work, and also the Florida Department of Health. So BTAN, the Black Treatment Advocacy Network, is a major partner. Empower You, Barinquin Health, AIDS Health Foundation, Care Resources, and others that we're consistently recruiting. The major aim of FPI is about engagement, and it really fits well with the spirit of our program and our team in terms of what we do. So in SHINE, a lot of our work is centered around empowerment and doing so from an aspect of resilience, specifically when we think about the Black community and what needs to be done to really end the epidemic. A large focus on social structures and psychosocial factors and thinking about what impacts disparities in access to care. And so FPI is really one of our model programs in terms of how we do the work. And this is an image of many of the members of SHINE. So with FPI on the left, you see a model here that we came up in terms of a framework of how we do the work. So it's within Miami's Black communities. And then we centered around 5 key types of venues. So laundromats, hair and beauty salons for women, barbershops for men, and car providing services. So car wash, mechanic, repair shops, and also corner stores or small grocery stores. Within that, there are consistently 5 different voices that are always there, right? So the team of SHINE, the community consultants, the businesses that we interface with and recruit and build relationships with, the community residents who we listen to attentively upon each engagement to think about how we could refine and do things better, and the community health organizations. And for the first year, in terms of the 1-year EHE, we were centered on 5 zip codes within Miami, the 5 highest prevalence rates for Black people living with HIV. But for the second one, we're actually expanding our reach to 12. So the 12 highest high impact zip codes. And what you see on the right is impact based on color. So if it's red, it's over 500, blue between 251 and 500. These are the 5 consultants I mentioned earlier that have a significant amount of reach in the community, are well respected. And their key role is, there are many roles that they play, but a big part of it is sort of knowing where to go in the community, what businesses attract and serve the Black community in these different zip codes, what needs to be done in terms of how we set up and how we deliver and how we engage people. So their voices are consistently there. We meet on a regular basis and we have consistent contact in terms of texting and talking about what went really well and what do we want to tweak to make better. So their voices are really a big part of doing this work. The community businesses, we go out and we literally approach them. So some of these businesses are known by our consultants, some might not be known, but they go out and they engage with them and they recruit the businesses. A lot of the businesses in the first round, I also help to engage because I'm a big fan of being on the ground yourself so that you have the insights and the knowledge and understanding of what needs to be done and what needs to be done better. So we literally drove around, walked around, approached businesses, gave them our pitch, spoke with them. And these are images of businesses in the first year that we partnered with to do an event. And essentially what happens at the events is that we go and we set up, you could kind of see an image on the bottom left to the bottom left corner where you see a tent, and that tent is actually in a parking lot, but we had space blocked off by the business owner. You see Barinquin's mobile testing unit over next to the tent. And what happens is that we block off space, we set up in terms of the SHINE team. And then what happens is that community members approach us, or residents, we engage them around taking a survey that's capturing information around health. So it's capturing information around HIV health, diagnosis, knowledge around PrEP, barriers to care, discrimination, mental health, and different intersecting issues around poverty and housing. And so we engage them around taking a survey, offering testing, information on PrEP, linkage if needed, and they get a voucher to spend in the business immediately. So for engaging with us, they get $20 that they spend in the business immediately. What that does is that it ensures that every partner at the table is valued in a concrete way. So the testing units, they like partnering with us in terms of the community health organizations because we're organizing all the pieces and they literally just show up and they get to increase their numbers and do the testing that they have contracts to do. With the businesses, they're increasing their revenue for the day, and for the residents, they were already intending to go into the business. So we're lowering the cost of the service that they're paying for that day. And this is just an image of some of the mobile units and vans from the different partners that we've partnered with. For year one, our preliminary findings in, I think it was 6 months before we got shut down because of COVID, we had partnered with 13 businesses and 5 different health organizations. We had engaged over almost 700 community residents, distributed over 12,000 condoms, and tested 131 individuals. For year 2, it's really about expanding the scope and tweaking the way in which we did things. So the primary outcomes are very similar around HIV testing, PrEP information and linkage, condom distribution, And the scope is 12 zip codes. But one of the things that's different for the 2-year expansion is that the HIV test that is required for the voucher in year 1, we didn't require the testing as part of the voucher because we were kind of trying out how that would work. But now we do require it. So in the context of COVID, we actually had our first event again post-COVID 10 days ago. And what we're doing is that we're still keeping the big parts in terms of engagement, community, value, and kind of the spirit and warmth that we bring, but with a lot of safety precautions in place. Obviously, we're outside, so there's maximum ventilation, but we have PPE. We're also gathering information on COVID impact and also their views on COVID vaccine. And provided additional information as needed. So basically when we do these surveys, there are questions that people have. And so we serve as a vehicle to empower and provide information as needed to the community. And that is it.
Okay.
I should say there are a lot of people to thank. So thank you everyone, included Steve and Charmin, all the people. Go ahead, Allan.
Okay, I'll take over. Okay, hi. So I'm going to talk about my supplement, which is advancing implementation of rapid response. And I'm going on behalf of my investigative team, which I mentioned there, Dr. Colbert, Dr. Harkness, Dr. Wojciniak. I'm going to present some of the preliminary data of what we have found. So rapid response or test and treat rapid response is pretty much giving antiretroviral therapy as close as to the diagnosis of HIV, ideally on the same day. So back in 2016, with the support of the health department and under the leadership of Dr. Colbert and myself, we pilot tested this initiative in Jackson. We have been successful. So far, we have over 600 people that have entered through this means, and this has taken over in Miami-Dade, and there's many other partners in the community that are doing it. So we wanted to understand how the implementation of this strategy is being done in Miami. What are the facilitators and the barriers? And this is the purpose of this supplement. And as Dr. Safren mentioned, it goes under the treat pillar. So the goals is to identify barrier and facilitator of the implementation of rapid treatment through Miami-Dade with a focus on reaching the communities that are disproportionately affected by HIV. And the idea is to use the findings to develop implementation strategies to expand rapid treatment implementation through the county. So we actually went ahead and did a qualitative interviews on people that were entering through this program. We interviewed, as we call them, community members. This is the findings of 31 patients that were recently diagnosed and entered HIV care to this program. And we also did provider focus groups. 3 of them were done in person. 1 of them was done through Zoom due to the COVID pandemic. And we have done this focus group with the South Florida ICE Network, Borinquen Health Center, AHF, and Empower You. And the idea was to assess the barriers and the facilitators of the implementation of this program. Pretty much these are the demographics of the patients or community members that were interviewed, and kind of reflects the demographic of new HIV diagnosis in Miami, which is mostly MSM, males, Latinos. But as you can see, there's a heterosexual women represented, and then there's the different modes of transmission, mostly MSM, followed by the heterosexual transmission. The interviews were analyzed with the partnership with Dr. Harkness and my research team, and there was a pair of coders that analyzed the interviews following the consolidated framework for implementation research, or called the CFAR. So as you know, we need to do implementation research and try to go under some of these frameworks to, this is what NIH wants us to do, and this is the implementation science moving along. So this framework, or the CFAR framework, is a framework that identifies at multiple levels what can help and get in the way of a new innovation being implemented and effectively scaled up in a given community. So the results are sorted in 5 domains. The 5 domains are mentioned there. Is the innovation domain, which innovation characteristic, which is what patients or stakeholders think about the in this case, rapid treatment. The outer setting, so what is happening outside of the organization that affects the implementation of the strategy. The inner setting, what is happening on each organization that affects implementation. The characteristic of the individuals that are being impacted by the intervention, and the process, or where the organization is on their implementation process. So these are the results. So we did it at each level of the level of the CFAR, and then we look at the community members or patients and the stakeholders. So in terms of innovation characteristic, and again, as I mentioned, these are preliminary results. The community members believe that rapid treatment is effective and is preferable to the standard way of treatment. So they feel it's good to get in care immediately. They feel that the rapid treatment simplifies the access for patients, but it can be overwhelming for some, as what we typically used to do in a few weeks to get someone into care, we're doing in 1 day or a few hours. So for some people, it's great because they can get there, but it can be overwhelming with the amount of paperwork, registration, seeing the doctor, following instructions. From the stakeholder point of view, or the clinics implementing it, they believe rapid treatment is effective and is preferable over standard treatment. And this was went along to all the places that we went. But they do feel that it can be complex at the clinic level to implement, especially at first. You have to put all the dots in line to be able to do it. But it does simplify it for the patients. In terms of the outer setting, there are some external policies, according to the community members, and structural barriers that can pose challenges, such as how far is the place where you can get the treatment, so insurance, transportation. Organization, but they feel that organizations already have a system and are automatically link someone from testing to clinic to facilitate access. The stakeholders feel that having connectedness to the HIV-related providers facilitate implementation. That's connectedness to case managers, testing personnel, and providers. Cultural and contextual factors can impede access, such as stigmatizing or the social context, and they do feel that insured patients are harder to connect at times than someone that doesn't have insurance can go directly into Ryan White. In terms of the inner settings, the patient feels that a provider organization that take a holistic approach, that show compassion, have warmth, is very important for engagement. So people feel that, empathy at the time of getting into care is very important. And also concerns of confidentiality and privacy, and making sure they feel this information is confidential is important. The stakeholders feel that we need to have well-established protocols that account for the complex eligibility situations, need to have highly effective communication, and throughout the organization, communication with case management, registration, providers, pharmacy. And that the leadership necessary needs to be on board and invested. In terms of the characteristics of the individual, patients feel that mental health and substance use should be bundled with rapid treatment services, because these are some issues that come along with the patient, and also to be aware that in some instances, newly diagnosed patients may not be ready to engage and get into care immediately. So this should not assume that everybody is ready. Stakeholders say that there has to be flexibility in terms of scheduling, administration staff, getting a patient in, and be proactive and committed to meeting the patients to implement rapid treatment, and that the providers and the staff need to be knowledgeable with this strategy and have a sense that they're capable of doing it and feel comfortable doing it. So in terms of the process, generally patients feel that it was effectively executed, but that there's insufficient outreach. Some people get tested in urgent care, emergency room, or was not aware they could come into rapid treatment, so it delayed them getting into care. So having more outreach and marketing of the program would be good. And in terms of the stakeholders, all the places feel that having a designated patient navigator that helps the patient navigate through this system is crucial to success of the program. And clinic has a sense that generally, most of the clinics that we went, they're already implementing it, but they all feel that there's room for improvement. So in terms of the potential implementation strategies, based on what we have found so far, feel that centralized technical assistance for linking patients to rapid treatment, probably useful. Conduct centralized and clinic-specific training for implementing rapid treatment. Help clinics establish workflows and that are flexible and specific to patient needs, so to know who's doing what, who can do what, and also to be flexible, to be able to do it as when the patient comes. To have formal relationship between organizations to ensure referrals to rapid treatment, and enhance outreach and messaging about the availability of rapid treatment throughout the community. So I want to thank the CFAR and my co-investigators and our community partners for letting us do this supplement. Thank you. I think I did it on time, 8 minutes.
Okay, I'm sorry. Okay, so today I am going to present the project that is finishing HIV. So we already have many implementation science projects that focus on Latino MSN who self-identify as gay. However, those Latinos who have sex with men and women and who believe that they are straight are also part of the problem. You know, they are the bridge between the gay community and the female community here in Miami. So finishing HIV fills this research gap through an innovative and tailored implementation science model for reaching large numbers of Latino MSNs, regardless their sexual identity. So finishing HIV uses the REAIM and the CFAR frameworks to first document progress and lessons learned through ongoing monitoring and process evaluations. And second, evaluate pragmatic rollout. And third, understand barriers and facilitators for successful implementation. So there are many people and organizations that were involved in the development and the current implementation of Finishing HIV, as you can see in this list. Finishing HIV is implemented here in Miami-Dade County, and it focuses on 3 pillars: diagnosis, treatment, and prevention. So this is Finishing HIV. Finishing HIV includes 4 networks: the social network, the radio network, the parks networks, and the pharmacy network. And we are implementing different activities to increase awareness and utilization of HIV services. So now I am going to talk about the social network. So in this year, we are going to identify factors and agents responsible for the successful implementation of our planned social activities, which will inform how to recruit and engage gay Latino MSN in PrEP programs. And there are different events that are currently being implemented by Latino Salud, our community partners. For example, they are entertaining events like Gamers Nights, Yoga on the Beach, and now many of these events have been moved to the online platform. We also have galas and festivals that they are also moved now to the online platform. And they are small group discussion groups with members from the community. So now I'm going to talk about the radio network. So in the radio network, we have partnered with the community radio Adictiva. So what we are going to do, because this is an implementation science project, we will assess the appropriateness of using different types of Latino influencers. for example, religious, sport, health influencer from the radio, and to determine what will be the best way to disseminate PrEP information in the community. We will have different activities that will be implemented in the radio. For instance, a radio novela, we are going to do it every Monday. We are going to have also commercials. And something that we have already discussed with our partner is that the topic of the first part of the radio network will focus on the World Cup, because that is what is hot now in the community. So we expect that we are going to reach over 217 Latinos per month. And now I am going to talk about the parks networks. So what we are going to study, with the park network is to basically detect contextual facilitators and barriers to the implementation of the park network. And what we are doing is we are partnering with Children's Trust, and they are going to provide the opportunity to their clients to receive some information, some PrEP information in over 100 workshops that they implement every year. And they are also going to be able to receive links with information from PrEP. So we expect that we are going to reach over 50,000 Latinos, male, regardless of the sexual self-identification. And now I'm going to talk about the pharmacy network. So our pharmacy network partners are CVS and Farmacia Navarro. So we are going to identify facilitators and barriers to implementing an EHE projects and involve corporate partners. And we are actually already implementing activities at CVS. The pharmacies are distributing flyers with information from the program, as well as some resources that are available at Latino Salud. So we are starting with few mini clinics, and so we are expecting to reach over 8,000 Latino clients. And we believe that this is a very good strategy, to reach Latinos who self-identify as straight but have sex with men, because they can go to a pharmacy to refill their PrEP, and if somebody sees them there, they can just say, I just came here to buy my shampoo. They don't need to release any information about the PrEP use status. So in this map, in the left, we can see all of the activities that we are planning to implement in Miami-Dade, and we have done an accessibility analysis to demonstrate that after this year, we will be able to reach a large number of the Latino community all over Miami. And this is our logic model that we have developed, and that shows the determinants, the different ERIC strategies that we are implementing in the project, as well as the mechanisms of how we are planning to have an impact in the community, as well as the outcomes. So I need to acknowledge the source of funding, and thanks so much.
Good afternoon. I'm Rosina Cianelli, and I'm going to present our project. We are in a very initial phase of the project, and our project is SEPA PrEP, a promising HIV prevention strategy for cisgender Hispanic heterosexual women to access, initiate, and sustain use of PrEP. And the different co-investigators, Dr. Joseph DeSantis, Dr. Giovanna de Oliveira, and Dr. Jose Castro. Here you can see a picture of our team, and Ms. Susanne Rubio. She is the executive director of Mujer. That's the organization that we work at in the rural area of Homestead. And we have here also our research assistant PhD student. So as you know, more than 19% of all diagnoses in 2016 were for cisgender women in the US. Of 1.2 million Americans that are eligible for PrEP, 38% of them are women, but only 7 to 10% are using PrEP. And these numbers are even lower among cisgender heterosexual Hispanic women. Why? Because they are, they have low awareness of PrEP and also limited access to it. And if we add also, there are some cultural behavior that also are increasing the risk of these women for HIV and also for not using PrEP, plus rurality, that's a problem. So to today, despite the compelling need, there are not evidence-based HIV prevention for rural communities cisgender women that incorporate PrEP. There are behavioral prevention strategies, but none of them incorporate PrEP. So our research is trying to identify barriers to PrEP, plus strategies to address this barrier. So in that way, we would like to equip the rural women with knowledge, self-efficacy, and access to use PrEP. So here, what is the significance and innovation of our program? I mentioned CEPA PrEP at the beginning in the title, and I want that you know that CEPA by itself without PrEP is a behavioral intervention that we developed specifically for Hispanic women. This has been shown to be successful in 3 different clinical trials, and also the effectiveness of CEPA was proved. However, we know that it worked with Hispanic women, but we know that it's not working well with women who are at high risk for HIV due to the risk factor they present, including the cultural factor that I mentioned before. So we think that CEPA incorporating PrEP to this intervention will help to achieve the EHE goals by promoting use of PrEP among rural cisgender women in the community of Homestead. So the CEPA actually does not incorporate PrEP, so we would like to develop an intervention that we are calling CEPA PrEP that is a biomedical intervention to prevent HIV. So we'll have the behavioral component, and the medical component that is the component of PrEP. So our goals or aims are develop a PrEP component that adapt CEPA intervention into CEPA PrEP specifically for rural women that live in Homestead, cisgender, heterosexual Hispanic women. We also are going to assess the feasibility and acceptability of CEPA PrEP as a prevention strategy and identify cultural behavioral barriers to PrEP uptake relevant to this specific rural community. Identify community and healthcare barriers and strategies to increase and facilitate PrEP uptake among this group of women and in community and healthcare settings. I want to spend more time in this graphic to explain more about the project. So we are using a mixed methodology approach. This is an implementation science, and we are using as our framework community-based participatory research. So if you look this diagram, We are located here, where faculty from the School of Nursing and the School of Medicine are the PI and COI of the study, and we are working closely with Mujer. Mujer is a community organization that is located in Homestead, that serve women who are suffering violence or any other problems in the community, and it's an organization that has been there for years. We have a long history of working together. So with Mujer, we also are working with another organization in Homestead, Florida Farm Workers, and the Rural Coalition. So these are our three main partners, and we are directly working with Mujer and the other two organizations. So our idea is, first, we are working at the present time. We start like 2 months ago with all the logistics of the grant. We are working, creating at this moment a community advisory board. The community advisory board will be created with people from the community. We expecting to have different leaders, people also from the three community organization, and Mujer is now looking for the people that they feel are the most appropriate. They are looking for them together with the other two organizations, and when they have the name, together we will review the people that they propose to finally decide who they are. So they will be helping us to identify barriers, strategies, facilitators that will help us to implement in the future PrEP for rural community people. And it's very interesting because with this community advisory board, we are going to train them. We have 8 hours of training in HIV, PrEP, and also in the CEPA intervention. So they know what are we proposing and what are we really presenting, because we don't know if they know about PrEP. So that's one of our important goals. Also, at the same time, we are recruiting 10 women who will participate in rural, in the focus group, women from rural areas, and the inclusion criteria for that women, they need to be between 18 and 49 years old, self-identify as Hispanic, self-identify as heterosexual, speak and read Spanish, be HIV negative or a no HIV zero status, have engaged in sexual activity in the last months, have at least one sexual risk factor for HIV, and we define the sexual risk factor as having one or more than one sexual partner in the last 6 months, unprotected sex, substance use before or during having sex with a sexual partner. Also, we request that they have a smartphone or an internet connection. We did our research, and around 80% of the home in the rural area of Homestead, they have internet, and of course, reside in the rural community of Homestead. So that's where we are now trying to recruit 10 women that will participate in a focus group, also to discuss about barriers or about if they know about PrEP, suggestion to implement in the future PrEP. And also we will be asking them about ideas that they have, how to present PrEP to the cisgender Hispanic heterosexual women in their community. So having the support and the advice of the community advisory board and the women who participate in the first focus group, we will be also having meeting with healthcare clinics in Homestead. These healthcare clinics are clinics that are giving care to persons in the rural area. So we are going to identify 3 of these healthcare clinics. Actually, we are doing together with Mujer and Rural Coalition and Florida Farm. And we are going to have a group discussion with this community or with this healthcare clinic in the community to also identify barrier strategies, facilitators that can in the future help us to implement PrEP. It's important to know that this healthcare clinic, 3 of these people in this group, they will be part of the advisory community board.
Yeah, Rosina, can you finish up, please? We're running short of time, sorry.
Okay. So this is in general what we have. I forgot to also mention that we will have 45 women participating in baseline assessment and focus group. We will train people from the different community to run the CFAR. So we hope that we are going to finalize with an excellent implementation science. Thank you.
Okay, thank you so much. So my name is Audrey Harkness, and I'm going to be talking today about my Career Development Award, which is focused on addressing Latino MSM health disparities by increasing engagement with both behavioral and HIV prevention services using an implementation science approach. So as is well documented, there are substantial HIV as well as behavioral health disparities that affect Latinx sexual minority men. And in Miami in particular, over the last period of 10 years or so, Latinx sexual minority men have been really the bulk of new HIV diagnoses. And alongside that, behavioral health disparities occur, which synergize and can worsen HIV disparities. And so one of the questions that's being asked is, how do we end the HIV epidemic, or how do we get to zero in the context of these synergistic health disparities that have been pretty pervasive and longstanding? And that's the big question that the Ending the HIV Epidemic initiative is asking. And so one of the ways to do that is to really scale up and disseminate what we know works. We know that PrEP and PEP, we know that regular HIV testing, those collectively are HIV prevention tools that can mitigate disparities if they're scaled up appropriately to the communities that need them most. Similarly, mental health and substance use treatment services that are evidence-based can also be scaled up, but haven't been, to address behavioral health disparities. And so with that, the project that I had recently gotten funded is a K-23, which is a Career Development Award, which fortunately for me means that I'll be able to, over the next 5 years, carry out both the research component that I'll describe, as well as training and implementation science and health disparities. So I'm really looking forward to being able to do both over the next 5 years. And so a few kind of key terms to describe kind of how I think about my project, as well as how I kind of think about implementation science as I've been learning it in order to develop the project, is that a clinical intervention is something that's really directly impacting a clinical outcome. So we think of PrEP, HIV testing, or behavioral health treatments at the bottom in this figure as clinical interventions. And then implementation strategies are things that lead to the scale up of that clinical intervention, which ultimately has an effect on health outcomes. So my proposed project is to develop a multi-level implementation strategy. So at a consumer-facing level, I'll be developing a program called Dime Más, which will be delivered to Latino sexual minority men. And the goal of that program is to enhance uptake of PrEP, HIV testing, and behavioral health treatment services. But there's also going to be a staff level component of the strategy, which will be a training program that will also develop and pilot test in the context of the intervention to make sure it's something that the multi-level implementation strategy is something that can really be used in a community setting. And so with that, the aims of the project are first to do some formative work to really identify, okay, what needs to be in this implementation strategy? How are we exactly going to define it? I have the general framework, which I'll show you in the next slide, but it'll be really tailoring that and making sure that it fits with both community needs as well as stakeholder needs. And then aim 2 will be to pilot test this within a community setting, not within a research setting. So this is a lot to take in, but I just am providing it to give sort of a bird's eye view. So this is our logic model that kind of defines the project. So in the determinants column, these are the things that can help and get in the way of Latino sexual minority men getting these services that we identified from our prior work. And then here on the middle left column, we have the multi-level implementation strategy. So aim 1 is really to develop this a little bit more. So from what we learned from our prior work, we have some idea of what DMMS and the training program will look like. But what we're actually going to be doing is collecting focus groups, and we'll do some theater tests and other kinds of formative work to really flesh out what this is going to look like, to make sure that it fits with community member needs, so Latino MSM who might actually receive DMMS, as well as stakeholder needs, so people in the community who would actually be delivering it. And then aim 2 of the project is really about the far to right columns. So how well does it work? So we're going to be doing a pilot test in the community to assess how well this overall implementation strategy does in terms of promoting PrEP uptake, HIV testing uptake, and behavioral health service uptake, but also looking at some of these implementation questions around acceptability, appropriateness, feasibility, and fidelity to the intervention, as well as how much it costs. So we'll be able to learn from that how it works and then be able to refine it further. So the idea behind this project is really to come up with something that's a well-developed, culturally grounded implementation strategy that's really based on community needs and organizational resources, and that the final product will hopefully be something really locally relevant and implementable. And so in terms of thinking of the short and long-term goals of this project, it's really to do our part in efforts toward ending the HIV epidemic by scaling up and disseminating what we know very well works to communities who have historically been insufficiently reached. And so that is the goal. And so with that, I appreciate everybody who has helped with this project, including my primary mentor for the project, Dr. Safren, and all of my co-mentors, and everyone in the HPAC lab, Charm, CFAR, and Claro. And so thank you. And if you are a community member or a stakeholder who would like to participate in focus groups, please do reach out. Thank you.